Good afternoon, and thank you for joining. My name is Jeannie Luciano, and I am the Senior Manager for Stroke with the American Heart Association. Before we get started, I'm going to go over a few items. Next slide, please, Tatiana. So just for your information, we want to make sure that you are aware of this is part of our Get With the Guidelines programmatic initiative. We are closing the gaps between evidence, guidelines, implementation, and equity, and we have a whole suite of Get With the Guidelines products. So today we are addressing our Get With the Guidelines Atrial Fibrillation program. You can find more information by going to heart.org, professional quality improvement, or scanning the QR code on the slide. Next slide, please, Tatiana. I'm going to, we have a wonderful speaker today, Dr. Dingxin Qin. Dr. Qin is a cardiac electrophysiologist at Massachusetts General Hospital in Boston, Massachusetts, and is an instructor of medicine at Harvard Medical School. He attended medical school at Peking Union Medical College and Tsinghua University in Beijing. Completed internal medicine residency and cardiology fellowship at the University of Pittsburgh Medical Center and clinical cardiac electrophysiology fellowship at Massachusetts General Hospital. He also obtained a master's degree in health policy and management at Harvard T.H. Chan School of Public Health. His clinical and research interests include catheter ablation of arrhythmias, left atrial appendage closure, lead extraction, and device-based therapy, including leadless devices. I think we have one more slide here. So this is just the recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. These materials are for educational purposes only and do not constitute an endorsement or instruction by the American Heart and American Stroke Association. So before we get started, just the webinar is being recorded and will be sent out to you via email within 24 hours. There are no CEs associated with this webinar, but you may access a certificate completion in your follow-up email after the conclusion of the event. You'll have the opportunity to submit text questions by typing them into the questions pane of the control panel. And you can send your questions in at any time, and we will address them at the end of today's presentation. If you have any technical difficulties, most of them can be resolved by refreshing your browser. If your issue is not resolved following the refresh, please refer to the GoToWebinar customer service team, whose contact information can be found in your webinar confirmation. So we are kicking off 2025 with a wonderful and informative talk by Dr. Qin. Dr. Qin, the floor is yours.
Thank you very much, Jeannie. Thank you very much for having me and for this great opportunity to give a short talk on the left atrial appendage closure. It's a brief review, and also we are going to talk about some practical considerations. I don't currently have any disclosure. So left atrial appendage closure for atrial fibrillation, especially for patients with moderate to high stroke risk, it plays an important role in it. And in 2023 guideline, it is a class 2A indication for patients who are contraindicated for long-term anticoagulation, and also a class 2B indication for patients who are at high risk for major bleeding or history of major bleeding. It's also important to note that this procedure is undergoing active investigation in many different arenas. And for example, for patients who are post-AFib ablation, there is a recent trial called Option trial, which was just published in New England Journal at the end of last year. They compared the strategy of continuing long-term anticoagulation versus using a Watchman device for left atrial appendage closure in this post-AFib ablation patient group. And what they found is that the left atrial appendage closure carries a lower risk of bleeding, while it's non-inferior for compared with long-term anticoagulation for stroke prevention. So we would expect this area to, this procedure to be continue to grow and in many different areas. So the rationale of left atrial appendage closure is that more than 90% of the time, the left atrial thrombus in non-valvular AFib patients are developed in the left atrial appendage. The pathophysiologic mechanism of this process is complex. It involves the structure and the anatomy of the left atrial appendage, which is like a very trabeculated pouch growing out of the left atrium. As you can imagine, in patients with atrial fibrillation, where there is no meaningful atrial contraction, the blood can become stagnant in that area. And with the stasis of the blood, there's local inflammation going on in patients with atrial fibrillation, which creates a prothrombotic state. And in addition to that, sometimes you can have minor endothelial injuries in patients with atrial fibrillation, and all these leads to thrombus formation in the left atrial appendage. So the challenge, one of the main interests for left atrial appendage closure is that there's just so many anatomical variations in left atrial appendage. You probably cannot find two persons who has the exact same form of left atrial appendage, just like our fingerprint. Broadly speaking, there are kind of 4 categories of left atrial appendage morphology. On the left-hand side picture, you can see panel A is chicken wing, and then there's windsock, cauliflower, or cactus. On the panel on the right-hand side, it shows a similar finding based on the CT scan and the 3-dimensional recreation of the CT scan. So the research in the left atrial appendage closure mainly take off after 2009, when the initial result of the PROTECT AF trial, which compared the first-generation Watchman with warfarin for patients with atrial fibrillation, was published. And since 2009 or 2010, you can see there is a significant increase in the number of research interest in these areas. In 2015, FDA approved the first-generation Watchman device. So currently, there are many different types of left atrial appendage closure devices, which is either commercially available or under active clinical investigation. So for example, there are ball-type device, which include the first generation or the second generation Watchman device or Wavecrest device. There's also this disc-type device, which kind of have a little lobe at the tip of the device to anchor it to the left atrial appendage and conform it to the structure, and then the more proximal disc, which provides a more complete coverage of the left atrial appendage. There are also suture-based devices like Lariat device, where it was inserted epicardially and then basically using this lasso to loop around the os of the left atrial appendage and tighten it so that it can create a left atrial appendage closure. There are also other types of devices like in the bottom panel, there are conformal device or laminar device. And also left atrial appendage closure is also performed routinely during cardiac surgery, where it can be either performed based on the suture-based closure or with the atrial clip device closure. So this is kind of a brief timeline of the left atrial appendage closure associated clinical trials. As we talked about in 2009, the first clinical trial, the PROTECT AF trial, was published, comparing Watchman device with warfarin. And after this, I think FDA was not entirely convinced with the result of the PROTECT AF trial, so they requested the company to perform another trial with a similar indication, Watchman versus warfarin. It's called PREVAIL trial. And after the publication of the PREVAIL trial, FDA granted approval of the Watchman device. In 2020, because the most common anticoagulation agents we use for AFib now is DOAC, there is a PRAC 17 trial which compared left atrial appendage closure versus DOAC. And interestingly, in this left atrial appendage closure group, the majority, more than 60% of them actually used the Amulet device, which was produced by Abbott. And about 30% of them used the first generation Watchman, and the second generation Watchman comprised of less than 5% of patients. And it was also showed a non-inferiority compared with the DOAC. And in 2021, the Amulet IDE trial results were published comparing Amulet versus the first generation Watchman device. And after that, Amulet device got FDA approval in the US. Also in 2021, a very important trial called a Pinnacle Flex trial, which is a single arm study for the second generation Watchman device, Watchman Flex device. And it was the result was compared with the first generation Watchman historic data and showed kind of a superiority of the Watchman Flex device, which is significantly improved outcomes. And then in 2024, as we mentioned a little bit earlier, there's option trial, which is an important trial for patients who had AFib ablation, and after that, either they were randomized to either Watchman versus DOAC. Again, Watchman was non-inferior to DOAC based on this study for post-AFib ablation patients. And there are a number of ongoing clinical trials going on for Watchman device or Amulet device. Importantly, there are Champion AF trial, which the result will probably come out in 2026 or 2027. It's a Watchman versus DOAC in the general AFib population. And the Catalyst trial, similar indication, is Amulet device versus DOAC in the general AFib population. So let's first briefly review the PROTECT AF trial. So the objective of the trial is to assess the efficacy and safety of Watchman device versus warfarin for stroke prevention in AFib patients. The inclusion criteria included non-valvular AFib patients with a CHAS score of at least 1. They included 707 patients. Intervention group, that is Watchman device implant, is 2-to-1 ratio, 463, and the control group is 244. The primary efficacy endpoint is a composite endpoint of stroke, cardiovascular death, and systemic embolism. And the primary safety endpoint is major bleeding, pericardial effusion, and device embolization. So this is kind of the long-term intention to treat outcomes with an average of 3.8 years follow-up for this PROTECT AF trial. We can see that on the event rate side, the primary efficacy endpoint, the intervention group is 2.3 per 100 patient years, and control group, that is the warfarin group, is a 3.8 per 100 patient years. Watchman group achieved non-inferiority, and this comprise of primarily stroke and cardiovascular death. For stroke in particular, we can see that even though the total number of stroke numerically is less in the intervention group, the ischemic stroke rate numerically is higher in the intervention group. It's 1.4 per 100 patient years versus 1.1 per 100 patient years. And the hemorrhagic stroke is lower, disabling stroke is lower, and cardiovascular death is lower. All of these achieve non-inferiority. And also in the primary safety endpoint side, the Watchman group did have a numerically higher safety events, 3.6 per 100 patient years versus 3.1 per 100 patient years. If we break these events down over time, we can see that the device group certainly seems to be non-inferior to the warfarin group in the primary efficacy endpoint. But on the primary safety endpoint side, the device group numerically has a higher safety event rate, primarily associated with the procedure complications. I think in this study, the procedure complication within 7 days of Watchman device implant is up to about 8%. And this was driven by pericardial effusion, sometimes even device dislodgement. So because of these, I think FDA did have some concern, and they requested the company to perform, the Boston Scientific company, to perform another trial. It's called the PREVAIL trial. So the objective of the PREVAIL trial is to further evaluate the safety and efficacy of the Watchman device compared to warfarin treatment in patients with atrial fibrillation. So the inclusion criteria is non-valvular AFib patients with CHADS score of at least 2. They included 407 patients, again 2-to-1 ratio with intervention group versus control group. The first co-primary efficacy endpoint is a composite of stroke, cardiovascular death, and systemic embolism. The second co-primary efficacy endpoint is a stroke or systemic embolism more than 7 days post-randomization. The safety endpoint is major bleeding, pericardial effusion, and device embolization. Regarding the result of the PREVAIL trial, we can see that the first co-primary efficacy endpoint, the device group is 6.4 versus 6.3 in the control group, so it's non-inferior. And the late ischemic co-primary endpoint, meaning that whether the Watchman is effective in preventing stroke after 7 days of the randomization, the event rate actually is a bit higher in the device group. It's 2.53% versus 2.0%. It reached non-inferiority endpoint, but it did generate some controversy over whether Watchman is actually effective in preventing these ischemic strokes. This will be, this is an ongoing discussion, and question will be answered later too. So for the safety endpoints in comparison to PROTECT AF trial, we can see that there seems to be a significant improvement in safety events. The PREVAIL trial, the implant success improved to about 95% versus about 90% in the PROTECT AF. The 7-day procedural complication rates is 4.5% in the PREVAIL trial versus the 8.7% in the PROTECT AF trial. There is a significant reduction in pericardial effusion requiring surgery, and also in procedure-related strokes. There is also a more contemporary trial called PRAC-17 trial, which so far is the only trial that compared left atrial appendage closure with DOAC directly in the high-risk AFib patients. The inclusion criteria included non-valvular AFib patients with CHADS score of at least 3 and HAS-BLAD score of at least 2. History of bleeding, requiring intervention or hospitalization, or history of cardioembolic event while taking a DOAC. So 402 patients were randomized with a 1-to-1 ratio in the left atrial appendage closure versus a DOAC group. The left atrial appendage device type is amulet in 61.3%, Watchman first generation 35.9%, and Watchman second generation 2.8%. So the primary composite endpoint is stroke, TIA, systemic embolism, cardiovascular death, clinically relevant bleeding, or procedural device-related complications. So if we look at the result of the PRAC-17 trial at 4-year follow-up, you can see that the CHADS score is average CHADS score in this patient group is 4.7, HAS-BLAD score is 3.1, so this is a higher risk group of patients. And numerically, the left atrial appendage closure group has a lower event rate overall compared with DOAC, because it's designed as a non-inferiority trial, so the left atrial appendage closure did achieve non-inferiority compared with DOAC. The table below shows kind of the event rate over time. So there is also a recent meta-analysis which combined the results because they are randomized, all the 3 randomized trials, the PROTECT AF, PREVAIL, and PRAC 17, to look at whether left atrial appendage closure versus oral anticoagulation for AFib will make sense. We can see that for the ischemic stroke prevention, left atrial appendage closure achieved kind of non-inferiority compared with oral anticoagulation. It achieved superiority in patients with for rates of hemorrhagic stroke and in cardiovascular mortality and all-cause mortality. For major bleeding, it did not achieve superiority, but for non-procedure related major bleeding, achieved superiority. So in addition to Watchman device, Amulet device is also FDA approved. The Amulet IDE trial was published in 2021 in Circulation. In this study, the Amulet occluder was compared with first generation Watchman device. It enrolled 1,878 patients at a 1-to-1 ratio and randomized to the 2 devices. It achieved non-inferiority for the primary safety endpoint and the primary effectiveness endpoint. However, it was noted that the procedure complication rates were higher in the Amulet occluder, 4.5% versus 2.5%, with a bit more frequent pericardial effusion and also occasionally device embolization. On the other hand, the left atrial appendage occlusion rate, that is defined by peri-device leak of 5 millimeters or less, was also higher for the Amulet occluder than for the Watchman device, first generation. That was 98.9% versus 96.8%. So in short, Amulet seems to be a reasonable alternative to first generation Watchman device based on this trial. And it seems to have a higher occlusion rate or more effective in occluding the appendage. But at least in the early trial, seems to have a bit higher procedure complication rate. In 2024, the Amulet IDE trial, the 5-year outcome was published. And as we can tell from this 5-year outcome, the overall event rate were very similar between the 2 groups. The patients free from oral anticoagulation in 5 years a bit higher in the Amulet group versus the Watchman group, 94 versus 91%. The annualized ischemic stroke rate of 5 years is very similar between the 2 groups. It's 1.6% versus 1.6%. The number of fatal or disabling stroke was lower in the Amulet group, and the number of DRT device-related thrombosis or peri-device leaks preceding stroke or cardiovascular death was also lower in the Amulet group. Again, so this is compared the Amulet versus the first generation Watchman device. And in 2021, the second generation Watchman device was also developed, and the clinical trial, the Watchman Pinnacle Flex trial, was published. If you compare with the first versus the second generation Watchman device, the second generation Watchman device has offered large size range and a shorter device. The distal tines of the first generation device was kind of open, and this can increase the risk of pericardial effusion during the implant. And these in the second generation device were resolved, and the tines were folded back. So it has a much lower risk of causing effusion. There are also a greater number of struts in the second generation Watchman device, where it conforms to the anatomy of the left atrial appendage a little bit better. There are also dual rows of anchors in the second generation Watchman device. and there's a reduced metal exposure. Hopefully that will reduce the device-related thrombosis. So the Pinnacle Flex trial is to evaluate the safety and effectiveness of the second generation Watchman Flex device. It's a single arm study, included non-valvular AFib patients with a CHA2DS2-VASc score of 2 for men and CHA2DS2-VASc score of at least 3 for women. They included 400 patients with a mean age of 73 years and a mean CHA2DS2-VASc score of 4.2. The primary efficacy endpoint included death, ischemic stroke, systemic embolism, or device or procedure-related events requiring cardiac surgery within 7 days after the procedure. And the primary effectiveness endpoint included the incidence of effective left atrial appendage closure defined by per-device flow of at least 5 millimeters at 12 months follow-up. So we can see that from the primary safety endpoint side, the performance score was 4.2 based on the historic data, especially from the first generation. But the event rate in the Watchman Flex trial is much lower, it's 0.5% only. And in the primary effectiveness endpoint side, 100% of the Watchman Flex implant in this trial achieved effectiveness, which means that the per-device leak is at most 5 millimeters, and most of them are much less than that. So to compare the first versus the second generation Watchman device, there's a study based on the using the National Cardiovascular Data Registry. And we can see that the in-hospital major adverse event rate was lower in the second generation, 1.35% versus 2.4% in the first generation, and the overall long-term event rate is lower, including lower mortality, lower cardiac rate of cardiac arrest, lower pericardial effusion, major bleeding, and device embolization. Overall, the second generation seems to be a significant improvement on both the efficacy and safety compared with the first generation Watchman device. And in 2024, at the end of last year, option trial was published. And this is a very interesting trial, included 1,600 patients, AFib patients with at least CHA2DS2-VASc score of at least 2 in men and at least 3 in women, who underwent AFib ablation. They were randomly assigned to left atrial appendage closure versus oral anticoagulation, mainly DOAC. The mean CHA2DS2-VASc score of 3.5 and mean Hasblatt scores of 1.2. So it's important to note that this group of patients didn't seem to have a very high bleeding risk based on the Hasblatt score. There are about 60% of patients underwent sequential left atrial appendage closure, meaning that they had AFib ablation first and then underwent left atrial appendage closure, typically about a few weeks later. There are also about 40% of patients underwent concomitant left atrial appendage closure. From the result of the study, for the primary endpoints, the safety endpoint, non-procedure related bleeding, the device group achieved superiority. There's 8.5% event rate versus 18.1% event rate in the anticoagulation group, which has a higher risk of bleeding. For the efficacy endpoint, that is death from any cause, stroke, or systemic embolism, the device group achieved non-inferiority. It's 5.3% event rate versus 5.8% event rate. And the secondary endpoint, the major bleeding events, again, the device group achieved non-inferiority with a 3.9% versus 5.0%. So based on this study, I think it makes sense for us, even though it's not in the current guideline, to start thinking about considering Watchman device in patients who underwent AFib ablation whether they will benefit from Watchman versus long-term anticoagulation. So most of the Watchman device, at least in our center, is implanted. They are implanted under transesophageal echo guidance. We typically the procedure is under general anesthesia. We have an echo attendant perform the transesophageal echo, and we as an operator basically will stand on the groin side of the patient and implant the device under both fluoral and transesophageal echo guidance. This is a case example. We can see it's an 88-year-old man with a history of paroxysmal atrial fibrillation with CHA2DS2-VASc score of 3 for age and hypertension, has a 6-sinus syndrome, has pacemaker implanted, frequent falls and prior subdural hematoma, so he was referred for Watchman device implant. So on the transesophageal echo, we look at the appendage from multiple different angles. We can see that there's a 0-degree view, 45-degree, 90-degree, and 135-degree. They all kind of show a different angle, a different shape of the device. And based on this, we will do some measurement to measure how big the os of the device, the left atrial appendage is, and whether we have enough depth to implant the device. And after that, we will make choice of the size of the left atrial appendage closure device, and we will do the implantation afterwards. So we can see this is the delivery catheter is inserted via transeptal puncture into the left atrial appendage. On the tip of the delivery catheter, we typically will put a pigtail in there and inject some contrast into the pigtail, through the pigtail, to delineate the shape of the appendage under fluoroscopy. And after that, we were comfortable with the shape and the size of the appendage. We chose the right size device, and then we perform the delivery of the device. So the device will be initially, upon initial deployment, it's going to form a flex ball with a partial deployment. And we can adjust the position of this ball and to make sure that it's have a good coaxiality to the left atrial appendage, and then we can gradually deploy the device under transesophageal echo and fluoroscopy guidance. So this is kind of the contrast shot after the device is deployed, but before the release of the device. So once the device is deployed, we're doing a contrast shot. We're using a TE to make multiple measurements from different angles to make sure the device is appropriately compressed and is stable, that the device will not fall out. And after that, make sure everybody is happy, and then we'll release the device. So this is kind of the imaging during the follow-up. We both have both the TEE, transesophageal echo, with a 3D reconstruction on the left-hand side, and also on the right-hand side is the CT scan data. We can see on the CT scan behind the device, there's a kind of an adequate thrombus formation, and meaning that the entire device or the surface of the device is completely endothelialized. And typically at this point, we're comfortable to say, okay, we can stop the either low dose anticoagulation or do an platelet therapy. We can transition to baby aspirin only. We also perform some procedures with intracardiac echo guided Watchman device implant, especially for patients who have combined afibrillation with a left atrial appendage implant, because just from the procedure flow standpoint, the intracardiac echo, we're using it for the afibrillation, so it makes sense for us to use it to guide the left atrial appendage closure as well. So this is, for example, this is a 70-year-old man with history of symptomatic paroxysmal AFib, had a PVI in 2023, had apical hypertrophic cardiomyopathy, has 6-sinus syndrome, recurrent GI bleeding while taking Eliquis. So presenting for a combined afibrillation and left atrial appendage closure. So almost all the AFib ablation in our center is performed with pulse field ablation nowadays. It's kind of we think it's a safer and faster procedure, maybe a little bit more effective for patients with hypertrophic cardiomyopathy too. So in this AFib ablation part, we can see that the right superior pulmonary vein has some reconnection. We fixed that. And then we also had a posterior wall isolation as well. After we performed the AFib ablation, we implanted the Watchman device. On the left-hand side, you can see there's a intracardiac echo catheter, which is actually positioned in the left atrium. For this case, for the Watchman device implant. And there is a delivery catheter going through a transeptal access with a pigtail catheter anchored into the left atrial appendage. Contrast injection was performed to delineate the shape and the size of the appendage. We make some measurement under intracardiac echo to determine the size of the device. And then we deliver the device under intracardiac echo guidance. You can see that on the left-hand side, we inject some contrast after device deployment, which showed adequate compression and adequate sealing of the left atrial appendage. And on the right-hand side, after the release of the device, we can see the device is sitting in a good position within the left atrial appendage. So this is a 2-month follow-up. Transit software echo basically showed it's a satisfactory device position with no peri-device leak. And at that point, the Eliquis was stopped and patient was transitioned to baby aspirin only. And there is so far no AFib after redo PVI and posterior isolation. There are many remaining challenges in this field for left atrial appendage closure, for sure. Currently, we only have still a limited number of clinical trial data, especially randomized controlled trials. That's why there are so many RCTs are still ongoing for patients who might need left atrial appendage closure in different patient population. There is a still ongoing concern regarding whether we can completely seal these left atrial appendage with these devices, even with the current amulet, for example, or also a second generation Watchman device. We'll still see about 10 to 20% of patients who have small leaks. I would say most of these leaks are probably very small, like less than 3 millimeter, but once in a while, we do have patients who have bigger leaks up to about 5 millimeter. So there's a lot of investigation regarding whether we can, optimize the device design to try to minimize the device leaks for these patients. In addition, there's also a risk of device-related thrombosis, which occurs in about 2 to 4% of the patients who underwent left atrial appendage closure. Historically, it's a little bit higher in the range, more like in the range about 3 to 4%. With the newer generation device, it's more like 1 to 2%, but it could still happen. So we do need some better prediction tool or mitigation strategies for these patients, because once you have a thrombus on these devices, kind of defeats the purpose of implanting these Watchman devices or amulet devices, because we have to use anticoagulation to dissolve these thrombus, which for those patients who are at high risk of bleeding, that can be a major issue. And also, including the procedure optimization, we have different strategies. We could use transit software echo, most of these patients are still staying overnight. Whether they can be discharged on the same day is a possibility. And also, we're using for patients who may be implanted with intracardiac echo. There are currently some 3-dimensional 3D intracardiac echo catheter available, which might help with optimizing these procedures. So if you look at the peri-procedural left atrial appendage closure complications, you can see that there's a recent study which is interesting, compared the Surpass registry, which included Watchman Flex implants in the US between 2020 and 2022, compared with the Amulet IDE trial. again, this is a registry versus a trial comparison, so the number might not be so directly comparable, but what we can tell, at least from the registry, that it seems to be the event rate seems to be much lower compared with in the trial. But we can also see that in the paired device leak side, there's still about 12.9% of patients, even with Watchman flex, there's a small leak less than 3 millimeter, 3.7% with a 3 to 5 millimeter leak. So this is a case example of a patient who has a device-related thrombosis. It's a 82-year-old female, had a persistent AFib, CHA2DS2-VASc score of 4, prior left atrial appendage thrombus, GI bleeding, underwent left atrial appendage closure with Watchman device. I think on this follow-up TEE, we can see that there's a small thrombus formation on the limbus side or the pulmonary vein side of the left atrial appendage. And it's confirmed with the contrast injection too. So for this kind of thrombus formation, for Watchman flex, based on the current data, it occurs in about 1 to 2.6% of patients. For the current generation of amyloid, it's a 1.5 to 3.2%. And because of the thrombus formation, we have to ask the patient to go back on the Eliquis in addition to aspirin, and follow-up T in 2 months show the DRT has resolved. And at that point, the patient was put back onto the low-dose Eliquis. There's a recent paper published in Europace which discussed the treatment of the device-related thrombosis. I think the general principle is that if the DRT is discovered, typically we'll have these patients placed back on oral anticoagulation or low molecular weight heparin. And we can have follow-up imaging, either a CT scan or transesophageal echo in 4 weeks. If it resolves, then we can go back to DAP, dual antiplatelet therapy, and have follow-up study. If it doesn't resolve, we may have to use a different anticoagulation plan or continue with anticoagulation for a longer period of time. So this is an example of a peri-device leak. It's a very small leak that we discovered on the CT scan. It's a 56-year-old man with history of persistent AFib with prior left atrial appendage thrombus, prior CVA, carotid stenosis, recurrent GI bleeding secondary to AVM, had a Watchman device implanted 2 months ago, was on Eliquis 2.5 BID after the Watchman device implant. And on the CT scan, what they show is a very small leak, is a 1.5 millimeter measured on the CT scan. And you can also see that on the distal end of the appendage, there is still no thrombus formation, which is also a suggestion that there is a communication between the left atrium and the distal end of the left atrial appendage. And this leak, in fact, is confirmed on the transesophageal echo. It showed a small peri-device leak at the same location, posterior aspect of the Watchman device, consistent with the CT scan. So because of this leak is a very small, it's a measure 1.5 millimeter, definitely less than 3 millimeter. This did not change our plan for transitioning patient to DAP, to antiplatelet, or baby aspirin. So for the current management strategies of the peri-device leak, again, if the leak is small, it's less than 3 millimeter, typically we don't have to change our strategy. For 3 to 5 millimeter leak, you may want to evaluate on the individual basis, because some of them might benefit from occlusion, either using coil or other devices, or even using ablation to occlude these leaks. But for those who has a severe peri-device leak, more than at least 5 millimeter, I think occlusion has to be shown to be better than medical therapy for these patients. This is a case example of left atrial appendage leak closure after incomplete surgical ligation. It's a patient with a 60-year-old patient with a persistent AFib with bicuspid AV, ascending aortic aneurysm, had appendage ligation in addition to valve-sparing repair of the ascending aortic aneurysm and ascending aortic aneurysm. We can see there is a partial reconnection between the appendage and the left atrium. So this closure was performed under intracardiac echo guidance. We advanced the catheter through the leak, and then through that we advanced the sheath into the leak as well. And then through this Agilis sheath, we inject some contrast showing the appendage is still connecting to the left atrium. And then we deployed a small ampular device to cover that leak. And for the post-procedure CT scan, we can see that the atrial appendage is completely closed and is completely thrombosed as well. So there's always an important question regarding what we should do after the Watchman device or the ampular device implant. There are kind of different strategies available at this point. For Watchman Flex device, the manufacturer recommended post-implant antithrombotic regimen is either oral anticoagulation for 45 plus aspirin for 45 days, and then aspirin with Plavix for up to 3 months, and then baby aspirin only. Or you can use oral anticoagulation plus aspirin for 3 months, and then baby aspirin only, or DAP for 3 months and baby aspirin only afterwards. For ampular device, I think the current manufacturer recommendation is DAP for at least 1 month, maybe up to 6 months, and after that it's baby aspirin only. So there's also this important or very interesting emerging strategy of using half-dose DOAC for up to 6 months, and then transition to baby aspirin only. The strategy of using half-dose DOAC was actually compared with the standard therapy in a recent study, where they put the patient either on DOAC plus aspirin, followed by aspirin and Plavix, and then aspirin only, or DOAC for half-dose DOAC for up to 6 months. And what they found is that the half-dose DOAC group actually had superior outcomes compared with the standard therapy group. The half-dose DOAC group had a lower rate of device-related thrombosis, had a lower rate of major bleeding, and overall lower composite endpoint. So in many of these patients nowadays, we are actually considering or placing these patients on half-dose DOAC if they can tolerate it. Again, as we talked about, there are many ongoing trials for left atrial appendage closure. It's a very actively investigated area. So the 4 randomized controlled trials available now is PROTECT AF, PREVAIL. Both of these are Watchman first generation versus warfarin, and PREG 17 is a left atrial appendage closure with either ampular or Watchman versus DOAC. And then the option trial is also available, is a post-AFib ablation patients, DOAC versus Watchman device implant. And there are other trials investigating patients who are end-stage renal disease, for example, whether the LA kidney trial, or in patients who are more general AFib population, with no significant bleeding indication, whether Watchman device will be non-inferior to the DOAC. That's a Champion AF trial for the Watchman device, and Catalyst trial is for the ampular device versus DOAC. There are also surgical left atrial appendage closure device trials going on, and many of these will be looking forward to these results. For conclusion, so I think we it's reasonable to say that left atrial appendage closure is a reasonable alternative to long-term anticoagulation for non-valvular AFib patients with moderate to high stroke risk and significant bleeding risk or contraindication for long-term anticoagulation. And left atrial appendage closure may also be considered for AFib ablation patients with moderate to high stroke risk. Sorry. And on other clinical indications of left atrial appendage closure, novel left atrial appendage closure devices, optimization of the left atrial appendage closure procedure, and post-procedure management are undergoing active investigation. All right, thank you very much for your attention. Now this is we have a discussion part, or?
Yeah, and I can there's some, you actually anticipated a lot of the questions, but there's just a few questions here I will get to. So one question is, how long do these devices last? Do you ever need to replace them?
We almost never replace these devices, and I honestly have not heard of or seen any case reports of replacing these devices, because these are designed to be permanently stay in the left atrial appendage.
Great. Next question, I think you referred to this, but what is the recommended time frame from implantation to repeat imaging TEE to ensure a good endothelialization? So it looks like 45 days. Do you ever do it again after that?
Yeah, typically about 45 days. That's correct. Sometimes because of the scheduling, sometimes I think within 45 days to up to about 3 months time frame is acceptable typically.
Great. Do these patients require prophylactic antibiotics when they're having dental procedures or other procedures done?
No, they don't. They don't typically require. Yeah.
Especially. Oh, go ahead.
Yeah, especially for the first 45 days. No. Yeah.
Do you have an age cutoff for devices, whether someone was too young or too old?
That's a great question. I think traditionally these Watchman devices or amulet devices has been implanted in the older patients because they are at a higher risk of having bleedings or falls or these kind of a relative or absolute contraindication for long-term anticoagulation. We don't have an absolute age cutoff. We certainly have implanted patients in their high 80s or even up to about 90 years old, if they are in a reasonably good shape for 90 years old. For younger patients, I think we're probably starting to do it a little bit more because many of these patients may have AFib ablation. They may not want to take long-term anticoagulation for the rest of their life. There's no absolute age cutoff for younger patients, but I think we're just starting to gain more experience in patients who are younger.
Great. So thank you so much, Dr. Qin, for really sharing your time and your expertise. I want to thank everyone for attending. And once you leave today's webinar, you will receive an email with a short survey, and we would appreciate if you complete that and provide your feedback. You will also get a follow-up email within 48 hours with a link to view a recording of today's webinar, as well as a certificate of attendance. So on behalf of the American Heart Association and our presenters, thank you for joining us today. Thank you, Dr. Qin, for your expertise. And thank you all for the care that you provide to your patients in your community. We wish you a happy and healthy 2025 and have a great rest of your day. So thank you. This concludes today's event. Thank you, Dr. Qin. Stay well.
Thank you.